welcome everyone for this panel session. We have a very interesting hour and a half ahead of us with four brilliant speakers, I should say. We're just been warming up on the discussion, but the idea of this plenary is within the context of urban health to look at the role of people in the role of population groups. We're going to cover from early age, small children and their carers, to young adults and their reproductive health, to older populations, and to workers and their ways of organizing and mobilizing. I'd just like to say as an introduction that we are really looking for having the opportunity to see what are the connections around this. Many of us know what to do in terms of the kinds of policies that we want to see in cities or the kinds of actions to take. However, the how to do it is much more complicated. And I think some of the people here in this session have been focusing exactly on the how. How is it that you get a group of people who have issues with, with their health and their well-being, or how is it that they can be actors and engage in transforming their urban environment? So I'll start. The plan for the session is that we'll go through the conversation with our four speakers, and then you can make questions in the chat and in the questions and answers, and we'll be collecting those and bringing them back to the group towards the end. But in my mind, I think, and I'll be coming back to that towards the end of the conversation, is what has happened with these population groups, how they were affected by COVID and how they are affected by urban policies in general, but also how is it that they can influence that urban environment to promote their health. I'll be raising things. Is it issues of organizing? Is it mechanisms for accountability, for communication, access to information? We've all, many of us in the conference have a lot of experience in these different aspects. I'd like us to bring back and to make the connections between the existing experiences from these four population groups into something lessons that can be used at the local level. So we'll start with our first speaker, who I'm pleased to say, can I ask the organizers that if you're going to see the speakers, because I'm not seeing anyone, only the
Yes, you will, Carlos. Yeah, I'll stop sharing the slides and then we'll speak.
Okay, can you? Thank you. So the first speaker, so it's good to see people around the table rather than speaking to a slide. The first speaker is Cecilia Vaca-Jones. She is the executive director of the Bernard Van Leer Foundation, and she has over 20 years experience of managing social and development policies and programs. Prior to becoming the executive director of Bernard Van Leer, she was the Minister of Social Development in Ecuador between 2013 and 2016 under Korea. She championed policies to improve the conditions of children, women and indigenous communities, including a cross-sectoral policy for early child development. Cecilia has also worked for several civil society organizations, the Organization of American States, UNDP, and has been a university professional. She holds a master's in social policies and sustainable development by the University of Bologna and a bachelor's of international relations from the Pontificia Catholic University of Ecuador, an executive master's degree in cities from LSE. Cecilia, very welcome, very warm welcome to you. Very happy that you are with us. Over to you.
Thank you, Carlos, and it's a real privilege to be part of this conversation. And I'm also very curious to see which are the different connections that we can find among the course of life, which I think we sometimes lose track of the importance of really being able to see across sectors, work in different levels, and of course, kind of like find intersections between different topics. So as you were saying, I work for the Bernard Van Leer Foundation, which is a Dutch foundation working at a global level. And we work with babies, toddlers, and the people who care for them. So today I'm going to share with you some of the experience that we started testing since 2016, which was trying to expand this logic of doing early childhood policy, just thinking about the children, but actually thinking about the environment that surround children. And of course, thinking that the vast majority of children nowadays are living in cities, we decided to work in cities. So let me share a small presentation that I have prepared for today, which I hope will be clear so people can get a better sense of what I'm talking. Can you see the presentation?
Yes, thank you.
Perfect.
Can you put it in presentation mode? I think it
Yes.
probably makes it easier to read.
Perfect. So this approach that we started working on 2016, we call it Urban 95. And the main question that we're asking cities, and when I'm talking about cities, of course, I'm talking about mayors, urban planners, architects, engineers, but also like families. And the question we want to answer is, if you could experience the city from 95 centimeters, which is the height of a healthy 3-year-old child, what would you change? And it's been really interesting, all the kind of answers that we get from asking this question. But I do want to come up with some conclusions that we've learned from the implementation of different programs. And the first thing is that children and caregivers do experience the city in a very different way than what many adults might experience the city. That the urban environments impact the way that caregivers behave. So it's important that we understand that by designing and planning the city, we are defining the way that caregivers can behave with their own children. We do understand that working at a city level involves a lot of cross-sectorial work, as I was saying before. And of course, when you're talking about early childhood development, we're also talking about working across different sectors. But for me, the most important thing is that early years has always been seen as specific policy that you deliver through services. And I think it's important that we start seeing cities as the possibility of influencing the health and the well-being of children. And the main reason for that is because, especially when you're talking about the well-being of babies and toddlers and the early years of life, we need to make sure that everything that is like influencing this well-being is really promoting better health, is trying to stimulate the way that the brain is developing. And the main reason I say this is because we also kind of foster the possibility that the immediate surroundings where children are being raised is creating these opportunities to create positive development. I just want to specify some of the areas that we work when we're thinking about working in cities, because I think this is relevant to ensure the healthy well-being of babies and toddlers. So we've decided to work in the public space. And when I'm talking about the public space in any city around the world, we're talking about streets, parks, sidewalks, plazas, playgrounds. But we're really thinking about how can we make this public space become like a live public space, a healthy public space, a safe space where caregivers can also feel confident that they're creating these opportunities for babies and toddlers. The second area of work has to do with mobility and of course, again, seeing from a healthy perspective and from the needs of caregivers of very young children and babies and toddlers. We do think about the flexibility that the mobility system needs to ensure, how safe, how convenient this can actually be for anyone living in a city. And the third area of work, which has been really enriching, is a neighborhood planning and how we can really make sure that when we're planning a city and when we're trying to close the gaps between poor and rich neighborhoods or more and less developed neighborhoods. We're really thinking about the needs that many of the families that have young children, how can we design the city taking this into consideration? And maybe I want to highlight which are the three main needs that we have identified, and especially during this COVID times. I think we've realized how important it is to ensure clean air for all, but particularly for babies and toddlers because of the importance of the development of their brain. And there's a lot of scientific evidence that nowadays that the impact of air does have an impact on the development of the lungs of baby, of course, of the hearts of babies, but also on the development of the brain that is so important in these early stages of life. The second important area that we consider needs to be explored and needs to be ensured when thinking about urban planning and design has to do with the exposure and the possibility to access nature. And this again, especially when you see it from the perspective of promoting equality in cities, we do realize that the gaps that you have in different areas of the cities are big, and we're trying to see which are the different solutions that we can bring into cities in order to bring back green and blue infrastructure to the cities. And finally, as I was saying, for me, one of the most important learnings during the implementation of our projects is understanding how important the proximity of services can be for families with young children. And this again has to do with the fact that we can ensure at least the basic services to be close to families and that can create this idea of community also from the perspective of how we plan a city. And just why these areas, and I think it's important from the perspective of early years to kind of justify why are these areas so important to work in. When you think about babies and toddlers, and we usually do this exercise with when we do like a live, especially when we have like live workshops. But I don't know how many people realize that babies absorb 4 more times air than an adult because babies breathe a lot faster than adults. So their exposure to air is very strategic on, as I was saying before, on the way they develop. I always like to think about air as the first public good that every human being has access to once that they're born, because that's the first thing that we do when we're born, we breathe. So we want to make sure that we can ensure good air for all if this is going to be so important in the development of your brain and lungs and your health in general. The other thing is we need to understand that, and this again from a perspective of an economy of care, when we're thinking about like moving around a city with a baby or a toddler, the timing and the journeys that we have are completely different. And finally, as I was saying before, I think it's very important to understand that that young children experience cities in a different way. And a lot of the experience of a city has to do with the way that their caregivers experience the city. And there's a lot of evidence, and we're gathering a lot of evidence again in this pandemic year of the importance of having access to healthy spaces that can reduce the stress and can really promote a better physical and mental health, not only for the young children, but actually for the caregivers that are basically enabling this or are also like transferring this energy to their children. And when we're thinking about working at a city level, basically what we want to ensure from a health perspective is we want to ensure that we, in the work that we do at a neighborhood level, we are basically promoting healthy connections. I like sharing this slide because for me, this kind of summarizes why is it so important to create this positive and this human connections. And as I was saying before, first of all, because these connections start from the minute that a woman is pregnant and the baby starts making these connections in its brain, and this synapses is what's going to really determine the future of this baby in their adult life. So if we can start creating these very positive connections from the urban space, that is the immediate environment that this child is going to be growing in, we're somehow ensuring these opportunities that this human being is going to be having in the future. But I like the way that we can tell the story in this slide, because basically we're talking not only about the connections that caregivers need to have with their own babies, but also about the connections that caregivers might need to develop with other people around them. This sense of inclusion, this sense of being able to connect with nature, with the immediate environment that is surrounding all of us. And I'll show you some pictures of how this slide has been able to translate into real examples through the work that we do. But so when preparing for this presentation, I wanted to make sure that I could learn some of the key lessons. I could share some of the key lessons with all of you. And I think with our team, what we have been able to summarize is that when we're thinking about planning and designing for cities, we really need to think that we're designing for the well-being of people. And this is, for me, the one of the most important learnings, and I'll show you some concrete examples of this. Also, it's important that when you're talking to these new constituencies, which can be these engineers, architects, the people that are in charge of designing the city, to consider the need of designing for caregiving, and because we have different ways of caring, right? We focus on the caregiving of babies and toddlers, but we have the care of elderly, we have the care of disabled people, and we want to build societies that care for human beings. And this is a concept that needs to be prioritized in the way that we design cities, if we want to have healthy cities. Again, the design for equity, as I was saying before, our main concern in the cities that we currently work in all over the world. But just to give you an example, we have great examples of India and Brazil and Peru, which have been deeply hit by the pandemic. And we realize that it's incredible how the pandemic does affect the most vulnerable areas in cities. And part of this has to do with the fact that there are such unequal gaps of accessing to different services. But in general, like the inequity that is projected in the cities is then also projected in the health issues. The fourth takeaway of our implementation of projects has to do with how proximity matters. People do need to be close to services. People do need to be able to connect to their community. People do need to be able to move easily. And finally, just a big takeaway, of course, because we care and we think everybody cares about babies and toddlers. We need to start thinking about babies, and maybe this is the best way to just take into account a principle when designing cities that can then work for everybody else. But I wanted to share some very concrete examples of the work that we have been doing, and this is, for example, work in the public space. So making sure that, for example, when we're working in the public space, we can prioritize, and as this picture shows, instead of using this space for cars that is not adding any value to this, like design for well-being, why don't we start designing cities for people and taking this public space back to people? This is an example of Lima, and this, of course, are tactical interventions that are happening in many different neighborhoods of the city. The importance is that you can make these things happen when you have the political will to actually do these things. We also need to design for caregiving. This is an example of a beautiful park that was recently inaugurated in Tel Aviv in Israel. And again, just thinking from the design, is there something that I can do differently that can basically promote these connections and these positive connections that we need to influence when thinking about the responsibility of caregivers connecting and really connecting with their children. As you can see in this picture is the fact of being able to bring nature back to the life of people, but also to create this design that basically enables these positive connections. Here I gather a bunch of pictures of different cities in Brazil, mainly Boa Vista and Recife. These are two cities that have been very engaged with the policy around early childhood development. But what I really like about some of the tactical interventions in Brazil is that they're really prioritizing working in the most vulnerable neighborhoods of their cities, and just making sure that they can bring some of this adequate public space for children to play safely, to also play in healthy spaces. As you can see in these pictures, we're not talking about the playground in the middle of a traffic street, but I think that the good practices is like choosing these places that are also safe from the perspective of being able to access to good air quality. Of course, proximity matters, as I was saying before, but it's not only about proximity, but actually about influencing different behaviors that can really ensure that from very, very early stages, people can also be active in practicing active mobility. As I was saying before, this slide shows how simple the normal journey of somebody who doesn't have young children is compared to somebody who has young children. So if we're aware of the complexity of journey of people who care for others and have caring responsibilities, then we can be more aware of how to design a city that works better for them. This for me is kind of like the perfect picture that is just like summarizing all those positive and healthy connections I was talking about before. And it's the possibility of really creating this urban space where you are basically enabling these positive connections. If you start analyzing this picture, you see you have nature, you have parents and pregnant women talking to their babies, you have the grandparent taking care of his child. So you have everything happening in the same space, people feeling included, feeling they can be part of a community. I'm aware of time, so Carlos, before you stop me, I probably just want to make sure that I also emphasize on three important learnings that we have around. We need to have more reliable data that uses indicators around children to show the well-being of societies. We need to emphasize on the use of behavioral science, because it's not about like designing the perfect space, but also promoting a change in behaviors and creating this idea of, if we want to care about others, we need to start creating that kind of positive behavior. The workforce matters, and as I was saying before we started this call, I think it's super important to start understanding which are those target frontline workers that are the real heroes. And as we all know, through the pandemic year, I think health workers have become like real heroes all of this time. But I think there are many frontline workers that are heroes every day on doing things. So why don't we start working with them and also to anchor some of this positive change in our daily basis? I wanna close my part just saying, if we can really make cities work for babies, I truly, and just from what we're seeing on the impact of the work that we do in 63 cities at the moment, I truly believe that we can create cities that can work for any other stage in life. Thank you, Carlos.
Brilliant. Thank you very much. Brilliant presentation, brilliant work. And I think it brings about a lot of not only how is it that the city influences the health of toddlers and small children and their carers, but also how is it that the carers and different mechanisms that you raise to get that transformation going in terms of focus, clean air, nature, public space, but also transportation. On the human part, the fact that you also be working with capacity building for carers, for healthcare workers, for other workers. I think that makes a very comprehensive view. And certainly a city for babies is a city for everyone. There's a comment on the chat saying exactly that the care city is, the city for all. So I think we're up to a very good start. And I'm happy to pass the words to Claire Finkel, who's a social science and international public health specialist, who has been working with family planning and urban issues in family planning in many parts of Africa. She was with the Gates Foundation, but she's been doing work in this area for many years, also in Asia. She's going to bring us some of the information that young people, adolescents have in their concerns, but also the solutions that they've been finding in terms of their reproductive health, which of course is very crucial for somebody who's a young professional. Claire, over to you. Thank you.
Thanks, Carlos. Can you hear me?
We do, yes, and we see you as well.
Great, thank you. And good morning, good afternoon, good evening, everyone. Thank you so much for inviting me to speak. I have been asked to speak about how urban family planning has fared during COVID-19 and some of the ways that women have navigated the restrictions imposed on communities because of the pandemic, with an emphasis on adolescents and youth. My focus will be predominantly on countries in sub-Saharan Africa. Adolescents are the fastest growing segment of the urban poor. Compared to older women, adolescents face greater gender, social, economic, and other structural challenges to achieving their sexual and reproductive health needs. By its very nature, family planning evokes significant sensitivity, and no more so than for adolescent girls whose sexuality and childbearing outside of marriage is frequently a source of public concern. While adolescents from all socioeconomic walks of life encounter unique barriers to accessing family planning, there's a need to understand the very different vulnerabilities faced by poor urban adolescents compared to their non-poor counterparts. Poor urban adolescents are more likely to have early sexual debut, both voluntary and forced, and early childbearing. They are more likely to engage in high-risk sexual activity, and they have significantly higher rates of unprotected sex and higher rates of transactional sex. They are at higher risk of unintended pregnancy and more likely to resort to risky, unsafe abortion procedures. They are also at disproportionately high risk of STIs, including HIV. In all these areas and others, poor adolescents have significantly worse health and social outcomes compared to non-poor adolescents in urban areas. Yet data on urban adolescents living in informal settlements are extraordinarily limited. As others have noted, their specific needs and vulnerabilities remain largely invisible to policymakers and program designers. So let me turn to COVID now. And the early predictions about COVID-19's impact on women's access to family planning were alarming. Numerous reports and calls to actions were issued, warning about the impending crisis for reproductive health. There was widespread accounts of health worker shortages, interruptions to the global contraceptive supply chain, diversion of funds and human resources away from family planning to COVID treatment and prevention, full or partial closure of health centers, and extensive community fear of becoming infected. So have these dire predictions borne out? To answer this question, I'm drawing on a variety of sources, from peer-reviewed publications, accounts from frontline service delivery organizations working directly with young people, informal accounts in the media, and the gray literature in the family planning field. But first, I want to say that this is not a systematic review. And second, there's a paucity of qualitative accounts of women and girls' experiences during COVID. Third, the quantitative data largely relies on phone or online-based surveys, and hence potentially bias the data to wealthier women and girls with phone and internet access. Finally, most of the results I reference use data collected from 2 to 4 months after COVID restrictions were put in place. this time period is too early to draw firm conclusions about how the virus has directly or indirectly impacted women, youth, and adolescents, given that the pandemic is still very much unfolding in several regions of the world. So I'll start with the qualitative data. A study out of Rutgers University provides perhaps the most comprehensive insight into the effects of the pandemic on young people's sexual and reproductive health, decision-making, and access to services. The study looked at youth age 18 to 24 in 5 countries through online surveys and focus group discussions. Adolescents younger than 18 were excluded from the study because of the sensitivity of the topic. Some of the findings include that over 50% of youth in Ghana and Kenya cited widespread fear of going to health facilities as a barrier to accessing contraceptive services. A lack of transport, curfew, and closure of the usual places where young people obtain their methods were also cited. 44% of the respondents, for instance, cited lack of transport. Reduced provider hours of operation was also cited as a challenge. Over 30% of young women in Ghana, Kenya, Uganda, and Zimbabwe who needed contraceptive services reported that the COVID-19 crisis had affected their access. And this finding is echoed throughout the qualitative accounts that I have come across from programs working closely with young people. Here are the results from Shujaz, which is a social media organization in Kenya, followed by over 60% of Kenyan adolescents and youth. While time prevents me from discussing the findings in detail, they are consistent with the previous study. The young man on the left, below on the left, he asks, am I supposed to buy condoms or am I supposed to eat? This next study is based on a survey of about 700 Ugandan youth aged 18 to 30. Adolescents under 18 were not included in the sample, and the survey was taken via an online questionnaire. Hence, only respondents with access to smartphones with internet connectivity and with an understanding of English are included. That said, the study found that STIs, unwanted pregnancies, and sexual abuse were the dominant concerns these youth faced. Reported barriers included lack of transport, distance between home and health facility, cost of services, and curfew. The authors concluded that Ugandan youths faced broad challenges to accessing sexual and reproductive health information and services during lockdown due to COVID-19. So let's now look at the quantitative data that look at the impact of COVID restrictions on contraceptive use and distribution. Given the previous discussion, these findings may be surprising, as they suggest that COVID did not lead to significant disruption of reproductive health services or effects on contraceptive use. Okay, so because of limitations, because of time limitations, I'm going to quickly move through these slides. Just to give you a sense of the trends. Okay, the first set of slides capture data, urban data from PMA surveys. These are large sample surveys, and with the COVID data collected via phone 3 to 4 months after restrictions were put in place in 2020. Unmarried women were not included in the survey. A key finding was that contraceptive use was fairly stable in Lagos and Kinshasa, with only a modest downturn. And there was even a slight increase in contraceptive use among women in need in urban Kenya and Burkina. There were many other findings, but the key finding is the lack of significant effects. The author conclude that their findings do not support the anticipated deleterious effect of COVID-19 on access to and use of contraceptive services, by women in the earliest stages of the pandemic. Here's another study, this time from the Full Access, Full Choice Project, also based on PMA data. But this time it's zeroing in on 15 to 19 and 20 to 24-year-olds in Lagos. The survey results indicate a fall in contraceptive use among 20 to 24-year-olds, but no negative effects on use for 15 to 19-year-olds. Note the dominance of condoms in the method mix for these young women in Lagos. I'm sorry. Lessons learned, huh? The next study uses as administrative data from urban and peri-urban areas of Mozambique. The sample of about 100,000 women are those referred for family planning by community health workers who were incentivized to encourage women to visit clinics for contraceptive services. Note that this likely biases the sample towards married or older women. So on the left, you see referrals made by promoters, and on the right, you see women's responses. There's a short-term decrease in the contraceptive receipt rate, followed by a rapid recovery in uptake. The authors conclude that the accessibility of reproductive health services was not dramatically reduced during the first phase of the pandemic emergency. And here we have a study assessing trends in contraceptive use among adolescents 15 to 19 who live in informal settlements in Nairobi, based upon phone interviews. Similar to previous studies, there is a short-term moderate reduction in contraceptive use followed by a rebound. An interesting finding here is the increased reporting of abstinence among these adolescents to almost 50% during the COVID lockdown in 2020. And now we'll look at service delivery data from the Challenge Initiative, or TCI, which is presently in 109 cities across 11 countries. The data source is HMIS. TCI specific focuses on the urban poor and includes all women of reproductive age, including adolescents and youth, married and unmarried women. The first slide shows a cross-city view of HMIS trends across TCI cities in Nigeria. The trends are largely consistent with those we have seen in the earlier slides. Temporary dip followed by a rapid rise to levels of contraceptive receipt higher than pre-COVID. And this is a view of, but the same data, but stratified by TCI states. And again, here you can see by state, and this is urban areas within the state, the rapid rebound, and some of which exceeds the pre-COVID levels. And the graphic on the right indicates a significant increase in condom use relative to other methods of contraceptives. And then finally, this is data from a project called Adolescent 360, A360, and it's for 15 to 19-year-old unmarried adolescents. It's not strictly urban. You can see the steep fall in attendance and adoption of contraceptive use starting in March 2020, followed by return to pre-COVID levels. Again, sometimes higher than previously. So almost all of the quantitative data shows a similar pattern generally, modest temporary dips, and even in a few settings, increases in contraceptive use. In urban areas, there are some indications that some communities and age groups fared better than others, but overall little enduring impact on access to contraceptives. While limited, data specifically for the urban poor appears consistent with this pattern. So these findings are in contrast to the qualitative findings, which indicate that the virus has upended young people's lives, and especially the lives of the poor, and that women's access to family planning was significantly disrupted. I wanted to end with a series of hypotheses about the seeming misalignment between the qualitative and quantitative data. And note that these hypotheses are not mutually exclusive, and that they could all be true. And I think because of time limitations, I'll just speak to two of these hypotheses. One is that family planning, that women prioritize family planning and will pursue all means to ensure they protect themselves from unwanted pregnancy. According to this hypothesis, yes, COVID-related hardships were pervasive and severe, but women and adolescents found ways to overcome them by and large. We have fairly strong evidence to support this hypothesis. We saw how quickly contraceptive use rebounded, sometimes even before restrictions were lifted. We also saw some switching of methods and greater utilization of the private sector, including informal drug sellers, to obtain methods. While the data for poor urban adolescents and youth are limited, the findings suggest that they made active choices about their fertility and maybe even demonstrated a high degree of motivation to postpone pregnancy, perhaps including for younger adolescents through abstinence. And then the final hypothesis I'll speak to is the limited data hypothesis. And limited data is likely partially responsible for the seeming discrepancies between qualitative and quantitative accounts, and maybe masking the full toll that COVID has wrought directly and indirectly on the lives of the urban poor, especially adolescents. The sampling and interview strategies introduce bias and result in missing segments of the population. The sample sizes are small and rarely disaggregated. Also, the surveys were conducted a few months after the start of the pandemic. We need more data over a longer time period to truly understand what is happening there. There's an invisibility of the urban poor, even under normal times. Under COVID-19, these knowledge gaps may have widened at the expense of our understanding of poor urban adolescents in particular. Thank you very much.
Thank you very much, Claire. I think you spoke very clearly about the need for data and the value of understanding what data there is. For the specific perspective of reproductive health and adolescent women in particular. Well, thank you very much. We'll cover two other population groups now. We'll go first to aging and older people. And I'm very happy to introduce you to Alana Officer, who's the unit head at demographic change and healthy aging at the World Health Organization in Geneva. And she's responsible for the delivery of the Decade of Healthy Aging with a number of stakeholders. She comes from work in disability, where she worked in many countries, many parts of the world, Africa, Asia, South Pacific. And she has done in their career in WHO a number of important landmark documents, like the Global Disability Action Plan, the World Report on Disability, the Guidelines on Community-Based Rehabilitation, and the World Report on Aging. And she's in charge of the WHO's work on age-friendly environments, including the related network and a global campaign to combat ageism. Happy to have you here, Alana. Over to you.
Wonderful, Carlos. It's fabulous to be here. So, good morning, good afternoon, and good evening to all. I just want to check that everybody can see my screen in full screen mode.
We do.
Perfect. All right, so I'm going to talk about age-friendly environments, and I am going to talk about the question that you asked, but which is what type of city promotes health and well-being in older age? So we know that making cities, age-friendly, and some people understand that as across all age groups, and other cities work specifically on older adults. So I think Cecilia and I could have a conversation around sort of age-friendly writ large. but it's an effective policy approach to sort of foster healthy aging across the life course, and in this case for responding to population aging, which is one of the key megatrends that we see happening globally. In an age-friendly city, we representatives work to adapt their policies, their services, their settings, their structures, really, to enable people to remain healthy and to remain independent and autonomous for as long as possible. So creating age-friendly environments requires an approach really across the life course to try and improve the fit between the individuals and the context in which they live. And to achieve that, obviously, we need to coordinate across stakeholders and across sectors. We need to respond to the great diversity that we see in physical and mental capacity, particularly I'm talking about in older age. There is, you know, while in COVID, we've talked about all older people as vulnerable, as if they're all exactly the same. We know that there is no point in life where you experience greater diversity. We need to respond flexibly, to, through multi-sectoral action to aging-related needs and preferences as they change. We need to actively work to reduce inequities, protect those that are most vulnerable, promote older people's inclusion in society. And really the aim of an age-friendly city or community is one that enables older people to age safely in a place that's right for them, be free from poverty, continue to develop personally and to contribute to their communities while retaining their autonomy and dignity. And obviously, because older people know very well what they need to be at the centre and consulted in efforts by local governments to create more age-friendly environments. So in 2007, WHO released a guide on age-friendly cities. Like Cecilia, we talked not only to children, but to older adults in 27 countries around what they needed from their cities and communities to be able to be and do what they have reason to value, i.e. to experience health and well-being. And after that, we set up a global network for age-friendly cities and communities that currently covers 1,300 cities in 42 countries, covering about 260 million people. That work is supported by 14 strategic partners at different regional, national, and international level. And we have a sort of a one-stop digital platform that provides guides and tools that cities and communities share, their profiles, good practices around things that they're proud of, that they would like to share with others. But really the intent of the network is to inspire others, but to show what can be done and how it can be done, to promote connections between cities and communities around the world, to facilitate information exchange, and to find innovative solutions. So I'm going to talk specifically around COVID and some of the challenges and the opportunities that COVID has provided in terms of the work around age-friendly cities and communities. And on this slide, you'll see that in the age-friendly city approach, there is a focus really on municipal level services. So whether that be in terms of housing or transportation, health and social care services, but also what do we do around place? So outdoor places, urban planning, and how do we support social engagement? Now, I think none of you will be surprised, but I just popped this one in to talk about the fact, I'm not going to talk about the death rates, but just to say that older people have been disproportionately affected as a result of COVID. And the image on your left shows across all age groups in terms of cases that are both confirmed and probable by age group. But if you look at the picture on the right, you can see who died. And older adults are those by a long degree who have actually died as a result of COVID. And what we can see in the cities and communities is an important response in terms of both preventing death, but really beyond that in terms of fostering health and well-being of older populations. So, for example, in Nantes, in France, a couple of days after lockdown came about in France, the municipality set up what was a Nantes mutual aid. And there, their intention was really to recruit volunteers, which they managed to do in a couple of days of recruiting 800 volunteers that reached in those first few weeks, 1,400 families with just essential items, so food and durable products for those that couldn't get out and about and get those themselves. And over the period of the pandemic, the city expanded this volunteer network to have 7,000 members, a large number of organizations, Red Cross, social welfare, broader partnerships than they'd worked with in the past to really continue to provide support in areas of health and social care and economic support going forward. All of these links that are at the bottom, and I'm happy to provide, is a more detailed case study from each of the cities around what they did and how they did it and with whom they did it, if you're interested. I want to move sort of across the channel and look at what Manchester did. So at the beginning of the pandemic, public communication around COVID was largely digital. But according to the National Health Service in the UK, the approximately 11.5 million people that lacked digital skills in the UK were actually 65 and older. So older people were reporting fear and they were reporting confusion about the virus. So the Healthy Aging Research Network and the University of Manchester, the Greater Manchester Combined Authority, and the Greater Manchester Older Persons or Older People's Network came together to develop what's on the slide, which was Keeping Well at Home, a really practical guide around, around the virus and understanding what do you need to do on nutrition, how can you prevent falls, how do you stay connected, what exercises can you do at home. So the booklet was distributed through local networks and communities, and then they did a survey of 500 of the recipients of that booklet, and they found that 92% found that it was useful, that of the people they interviewed, 50% didn't actually have access to the internet, and 65% said that they would not have got access to that information if they hadn't received the booklet. So just challenging this idea in terms of information and communication that maybe for certain groups, print-based communication is not so out of date. If we move through to Singapore, the pandemic we saw had a huge impact on access to social activities, social services, and support networks. So as part of a much broader program from the Singapore government and the Singapore city, they really looked at how they could support people to basic needs, be mobile, meet their basic needs in terms of food and other services. But they also taught older people how to use smartphones, QR codes, how to use WhatsApp and Wi-Fi to really stay in contact. So COVID, from WHO's data, we found that about 40% of countries report a disturbance in essential care services. And one of those, for example, in this case study, was in Gangdong-gu in South Korea, where they actually had to close the dementia care center. And so what the municipal government did was they set up a remote medical assessment service. So working with local nurses, they sent nurses to homes to be able to do an initial assessment for people. And then they provided the infrastructure such that people within their own home could get actually tele-assessments in terms of dementia. But it was also a great opportunity to link those people, because a lot of the people the nurses visited didn't need dementia assessments, but they needed other support and care services. So linking with existing networks and existing services within the city. And this was really important in terms of improving equity as well. So a lot of people who weren't actually getting access to those assessments were able to through tele-assessment services. In Lethbridge, for example, in Canada, and I just wanted to highlight this example because I think they surprised themselves. So the community came together on Slack. They brought together all of the community organizations that they could. So police, public libraries, Indigenous organizations, not-for-profit charities, faith-based organizations, to really look at how they could pool their resources in the response. They also set up a more community-facing network so that people could demand services, so they could look at trying to ensure that supply met demand, really. And they did everything from the fact that restaurants were not operating, hotels had additional food, so how could they distribute that with a focus on people who were poorer or homeless in that case. They worked with the school systems to support families around access packs and improving resources for families, both food, groceries, but also in terms of IT, where they needed it to maintain schooling. All of the services that they did, they partnered with disability services to ensure that people with disabilities were not being left behind in the provision. So I think, the feedback from Lethbridge was that they were, they realized that they could work really well together, that they were really happy with their way of coming together. They realized that digital platforms could support that networking and collaboration, and that they could do that, ensuring that people were not being left behind. The last example I just wanted to look at was Limerick in Ireland, and mainly because they had a very strong program pre-pandemic. Limerick is part of a broader national program around Agefriendly Ireland, where all of the counties in Ireland actually are part of that network. And I think the lesson that we learned here was where there was already existing infrastructure, they were able to scale up incredibly quickly in response to the pandemic. They set up a community call center staffed from 8 to 8 for older people to get access to prescription drugs, to get access to food and money. They set up another center where anybody who was feeling lonely could talk to somebody. They partnered with libraries and the council to ensure that they could do outreach to hospitals. But I think that the main findings were that even if they had a really strong infrastructure beforehand, they strengthened their organizational linkages, they established new communication channels, they really worked to improve the trust of older people with the public agencies. They worked to address the digital divide, so they took face-to-face training and then made it online for older people. And they continued to consult with older people, again, to ensure that supply met demand. So, Anne, who works in Agefriendly Ireland, was very conscious that in the work they did, that while we might need to distance now, we can come closer through other mechanisms, and COVID showed them how they could really do that. So there have been a lot of consequences as a result of the pandemic. They were existing harms, we knew about them. They were incredibly exacerbated as a result of the context in terms of ageism across all age groups, whether we're talking about all older people as being vulnerable or all younger people as being invincible, or the cause of the transmission of the virus. Ageism has been ubiquitous in terms of this pandemic and incredibly damaging. And WHO just released a report on what you can do about addressing ageism across the life course. Long-term care, it's just showing up the gaps in our long-term care service. And WHO there has also got some useful guidance around how to prevent and manage COVID within long-term care. Rates of elder abuse have increased as a result. And social isolation, and I'm showing you a little, brief there in the sense that we're going to launch this brief on the 30th of July, but you're getting a little teaser around just the extent of social isolation and loneliness and how that's been exacerbated. So these are harms which we haven't addressed adequately within cities and communities, but have been incredibly prevalent as a result of the pandemic. So how are we going forward? So this year, the UNGA actually, last year, designated 2021 to 2030 as the decade of healthy aging, an opportunity to come together as a global collaboration with states, civil society, businesses, media, academics, to improve the lives of older people, their families and their communities. And the focus is all areas that the COVID pandemic has really highlighted as being major gaps in terms of older people, changing how we think, feel and act towards aging, building cities and communities that foster the abilities to the health and well-being of older people, improving integrated care, and ensuring that those people who need care, long-term care, get access to it. So we've also just set up, and we've launched in English, and we'll launch it in Spanish and French in the next month, but a platform where all of the knowledge that can be used to foster healthy aging is available in one place. And we just released last week a series of country profiles for 194 countries, which also includes whether they have age-friendly cities within the country. So this is a database which is useful to look at how we can build this work going forward. But in terms of the future, we do need to do a lot of work on building capacity, on strengthening the linkages where we see where there are national programs and local action, they're much stronger, they're better sustained, there's much better collaboration between national policies and local action. So we're going to develop some new national guidance on that work. We're looking at what could be some of the best buys around multi-sectoral action at local level that really focus on improving outcomes for older people. We need specific actions to reduce inequities for people who are socially isolated, who are experiencing neglect or abuse. And we need to strengthen the engagement of older people. As Dr. Tedros said, older people need to be central and fully engaged in all of the work that they do. They're actively involved as co-researchers in developing age-friendly cities and communities. A lot of cities and communities have specific older persons councils that drive action, but that's really an opportunity for expansion. So that is me in 12 minutes or less of some of the work we're doing around age-friendly cities and communities. Thank you very much.
Thank you very much, Elena. Very much appreciated the experience with Agefriendly. Covering 260 million people sounds like a lot. On the other hand, you also see the rest of the world, and how is it? So I think that this experience is very useful to think of how we can focus on the rest and where are the opportunities. And I think you stress some of the points that Cecilia was showing at the beginning in terms of working with the workforce and how is it that we can build capacity, but also in terms of engagement. And I think Cecilia was showing some specific examples of engagement in the value of evidence that was stressed also by Claire. We now move to our final presenter who comes from a more political perspective. And I'm very, very pleased to introduce you to Sharon Burrow, who's the General Secretary of the International Trade Unions Confederation. She's also a former president of the Australian Council of Trade Unions, and she was the first woman to become General Secretary of ITUC since its foundation in 2006. She comes from a small town in New South Wales. It was born into a family with a long history of involvement in unions and the struggle to improve the lives of working people. Her great-great-grandfather was a leader in the shearers' strike in 1891, and he ran for the Labour Party in New South Wales in 1896. So there's a long family history there. But more important, Sharon has built a career, and her life's work has started as teaching and then teachers' unions and mobilization. But she gradually moved to being president and vice president of the trade unions, the Trades and Labor Council in the region where she was. Then she moved into the Education International, which involves a lot of international organizations and unions involving teachers, moved them to the Australian Council for Trade Unions, and she's been the president of the International Confederation of Free Trade Unions in Asia Pacific region before becoming General Secretary of ITUC. She has been a member of a number of bodies at the ILO, the International Labour Organization, and is a member or ambassador of a number of international commissions on climate action, on industrial transition, and economic forum. We're very pleased to have you here, Sharon, with us in terms of the thinking, where many of us have been working from the perspective of science and knowledge. Others have been working from the perspective of urban organization and structures, and you come from basically a perspective of people's organization in terms of trade unions and workers. And I think we're very pleased to hear you and your perspective, and how is it that we can engage more with these different population groups, and perhaps what are the mechanisms that the trade unions or workers have used in the context of cities or elsewhere, and is it, what is it that makes them heard and makes them change their environments? And I think your DNA is around those processes of change. So I'll say, I've raised at the beginning that, is it more accountability? Is it participation? Is it communications? Is it ways of organizing? But certainly I'll pass the word to you now, and we're eager to hear what you have to say to this conference, which builds some people from cities, urban planning, and from health and public health. Thank you.
Well, indeed, Carlos, it's all of those things. And can I say, I'm really intrigued and privileged to be part of this discussion, because, you know, it was just an incredible treat to hear all the panelists put people, whether it's children, whether it's aging societies, whether it's essential workers, at the heart of their thinking around what constructs, in our language, livable cities. You know, the majority of people on the planet live in cities. They're only going to grow. But indeed, we've seen everything that is wrong with our society reflected in too many of our cities, from, you know, dehumanizing poverty to the lack of capacity to meet and work with other people, or even to socialize in their communities. So when you add what I would characterize those trends as, you know, increasing and historic levels of inequality in our societies, when you marry that with the climate emergency, and indeed the global health shock that we've just actually all, well, experienced, but are still living through, and in too many parts of the world, you know, facing daily the crisis of death and the loss of lives and loved ones, then we know that you can no longer think about our cities as simply separate silos, that you have to look at what will it take to build living cities that has to put people, planet, and shared prosperity at the heart of the way we think and design our communities. So I must say to all of the panelists, and to you for leading this piece, thank you, because it's such a rare privilege to hear people focused on other people, and then the infrastructure, and then the financing, and then the accountability, as you say, to what will make that happen. I do obviously believe that if we're not organising people and allowing them to participate in designing their own lives and futures, then we're actually not creating the kind of living environments or the working environments, or indeed the sustainability that we would all aspire to. So for us, cities, when you look at the current areas of crisis for the workforce, are absolutely fundamental. They're not only fundamental to people in the city, but because of demand and supply, they're fundamental to the catalyst for demand that actually affects production and services, whether in the city itself or in the hinterlands or in communities around the world. So, you know, having a heartland that where cities are seen to be involving all aspects of our life is absolutely, you know, where we need to start. And talking to each other today, I think, is a great, you know, perhaps a great catalyst for more communication, so that we actually listen to each other. From a worker's point of view, we are facing now a convergence of crisis. As I said, massive levels of inequality. We've seen that become even more dramatic since the 1980s and hyperglobalization and the trend data that shows the explosion of cities. But we've also seen it in that period and slightly longer in the failure to have a just development model for cities outside of the developed world. So when we think about inequality, and then we add the climate emergency and now a loss of biodiversity and the breaking down of barriers between our environment and indeed our capacity to generate security of health and sustainability. And when you add COVID-19 as a global health shock, then there's no doubt that what we have had exposed to us is the dangers of not paying attention to making sure that we have inclusive and indeed, rich participation of people in designing their own future. So for us, if you're tackling the climate emergency and equally unemployment, then there are jobs. In terms of the transition, every industry, every sector must make for climate transition to get to a net zero future. There are jobs, whether it's in infrastructure, whether it's in agriculture, whether it's in indeed services or transport. And I was struck by the intersection that Cecilia painted of community, mobility, and interconnectedness with services, because we see the same thing for essential or frontline workers, exposed indeed, as Cecilia said, through the pandemic. But our gratitude is short-lived when we don't think about the conditions in our cities for them. It's not just about income, it's about security, but it's also about mobility and affordable housing for workers who are very low paid, just as it is for the aged or indeed those communities excluded from work and a living wage or decent or the security of opportunities. So there are jobs in the transition. And then when you look at resilience, we have to have social protection, and that has to include those vital care services. It's health, but it's education, it's childcare, it's aged care. If we're not looking after people and helping each other look after people, then we don't have the kind of living societies that are based on the humanity and the values we would want to share. So we see, full employment equally importantly to sustain individuals and their families, but also to sustain the care economy in our societies that has been underfunded. We can never again see our care sectors, health, education, childcare, aged care, all of the things that support people underfunded, because COVID-19 showed us what happens when we actually simply avoid those essential services that we've grown up expecting that that's what we paid our taxes for, that that's what we want to be able to support. And can I tell you, for women workers, we see increasingly the insecurity of their work. It's basically low paid, insecure contracts, short-term contracts, often unsafe work. But that's in our formal economy, where in fact we have only 40% of the global workforce. If you go to any city around the world, people think it's only the developing countries. And of course, it's magnified by a factor of many there. But informal work, where there's no minimum wage, no social protection, no rule of law, no hope and day-to-day survival, we can build jobs, good jobs, in care. We can build them in climate response. We can build them in sustainable energy, in respecting agricultural transmission, and of course in transport and construction and so on. So what we need to do is integrate our thinking about people, integrate a commitment to full employment and the dignity of decent work, and integrate the living infrastructure that our cities provide in order to make all of this possible. So I would suggest, if we're looking at how we do that, then it means having people at the table for whom we're designing the environment. Certainly that's what we call just transition in terms of climate or technology changes in the workforce, but it's equally important that our cities are, our leaders in cities are supported with both finance and capacity, but we are also making sure that people are supported to be at the table, to have a view about sustainable cities in that broadest sense of the word. So we always see the dignity of decent work at the heart of security and opportunity, but without all those other areas of care and you know, servicing and industrial support, it's not possible.
Super, excellent. I think very inspiring, very thoughtful. And in terms, and I think very useful, if I can say, in terms of moving forward, because looking at these big challenges and the fact that they are systemic and they have very strong connections. So not only we saw so far, and I'll open to the discussions now, how much what is done for younger people, or people who are smaller than 95 centimeters, helps what is older generations, but how much the same sort of in terms of urban infrastructure. But the fact that all these population groups are facing similar challenges, which are very big and very systemic. It's climate, it's pollution, it's decent jobs, and it's, as I think you said, you put it very well, Sharon, is how much we can bring all these groups at the table of the just transition. How much is it that the care economy doesn't have to be something that, you know, was useful during the COVID acute phases and now are not heard any longer. So in terms of mechanisms that we can be using to help bring people to the same table, I'll open the discussion now for us to put other thoughts. And there's a couple of questions. They relate specifically to the use of social media, and it was directed at Claire and how much social media was helping or not to address some of the lack of access to the reproductive health services. But I think this has a sort of a more general nature of what kind of mechanisms can be invoked to bring people at the table and to see what is it at the table, what is this table set to do. And I think those bigger questions are also important. I'll come over to you first as a sort of a round of reflections from the conversation so far. Can we start with you, Cecilia?
Thank you, Carlos, and thank you everyone, because I think it's quite enlightening to see, and you know, I was referring to how when you design and plan a city that can work for babies and toddlers and young children, it can work for any other stage in life. After listening to Alana, I realized that there's so many similarities on what you can do also for an elderly group, right? And for me, is this the fact of how can we align this interest on the different stages of life, and but how we can really convince these new constituencies of people who are not really necessarily seeing people in the center of designing or planning or closing the gaps. And Sharon, you were referring also to the inequity, and a lot of that discussion has to do around the economy of care. And for me, even just putting that topic into the table is quite powerful. I remember back in my country, at some point, we did this exercise of trying to give an economic value to the care activities. If we would have to give like a monetary value to the caring activities, that of course it mainly relies on women work, on for example the caring activities in the households, and we were able to come up with a number that represented like 15% of the GDP. If we would have to pay to every woman who's now taking care of either young children or elderly or disabled people, we would have to spend like 15% of the GDP. And of course, we're not spending that. But I think that having that kind of data that also creates this awareness of how much of the care economy relies on women and people who are not seen and who are not recognized. Also makes us aware of the opportunity, as Sharon was saying, maybe we can start building good jobs on care, because it's something fundamental for the well-being of society. So yes, I think there's a huge opportunity of just finding ways of aligning these objectives of just basically redesigning cities and thinking from the perspective of people.
Excellent. Thank you, Cecilia. A good start for this conversation in terms of the alignment and where we go with the alignment. Claire, can I pass it over to you? For your
Sure,
reactions
thank
and
you.
thoughts.
Yeah, and I'm having a little bit of internet connectivity, so I'm keeping my video off. Apologies. So one of the questions posed, I think, was around social media and the role it played. It was an interesting question. I think that it was asked whether it exacerbated rather than sort of alleviated social concerns around the COVID. And I haven't seen signs that social media is always more effective to circulate rumors and myths and bad difficult information. But it was certainly used, the platforms were used to bring people together virtually, of course, to share messages about where family planning can be obtained, sometimes in the absence of government information about this. It was used to support health workers virtually. Previously, there was in-person support, and that wasn't possible. A lot of the person-to-person engagements became impossible under COVID, and still are to some extent. And I think it also, under the Shujaz project, the Shujaz fans, they call them, they videotaped themselves in their own communities and shared their concerns, what they were experiencing, some of the ways that they were able to circumvent challenges. There's a sense of solidarity that is being created through social media, I think, by more vulnerable groups. So it's a very active and interesting area and dynamic area of learning. And I think we'll certainly get more information as time goes by. Thank you.
Thank you. Alana, can I pass over to you for your thoughts?
Sure, Carlos. I think one of the things that, this conversation is really stimulating in me is really how to, Sharon talked about how to think about it from the person. And when we're doing that, how do we think about it from the fact that, a person is not just their age or their sex or their level of capacity. And then how do we really, in the way that we do this, because, obviously I've come from an older person's perspective, yeah? But really, where are our ways of rethinking that sort of intersectionality, those diversity that people bring? And where are those synergies? And how, if we think differently about the way that we design our cities, for example, not only the benefits that we get, for example, by making curb cuts and making more accessible streets and slowing down the time for crossing, how that benefits older people, people with disabilities, and young toddlers getting across the street. But how do, when we design spaces, we do it to foster intergenerational contact, yeah? Because by improving and bringing generations together, we can also change how people think, feel, and act towards those different generations. So that's an added benefit in terms of how we design and create our environments. So, I think that there's a real opportunity for all of us to be working and thinking more together around where are those maybe best buys from a life course perspective, where cities, when they're having to make difficult choices, how can they invest in in the way that they design and the services that they provide that can benefit the greater number of people in the more inclusive way that they design their cities. So I think that there's some real opportunities across the life course. And I think, you know, I really echo also, I think Sharon and Cecilia's points around care and understanding the sort of care economy and the role of local communities, because a lot of those services are decentralized to cities. So how can that care economy be supported? And I think of that from an older person's perspective, who provide an enormous amount of care. Yeah. So, you know, how many times do you seek your grandparents in terms of childcare? So, and when you look at the numbers of older people who care for other older people, just, you know, how important they are in terms of the care economy. So really thinking around the care economy also from an inclusive age perspective, I think is a real opportunity that's coming out of this discussion.
Super. So I'm going to open to the questions have been addressed individually. I think Elena responded to somebody, and Claire just responded on the mechanism of using social media, the risks of infodemics, and how it can be used positively. I think I'm going to bring back the discussion to this idea: is that at the table, the common table where everybody sits, or is the common platform? And perhaps where is it that we could be visualizing something that could be bringing these different strands together? And maybe it is part of it, it is around the care economy. The fact that we all are engaging with health workers and carers in different ways. And are there ways, and you all mentioned capacity building and strengthening ability to negotiate, to influence. Perhaps that's something that we could take out of the session as one of the common elements that we could sort of draw upon from the different experiences and see what are the synergies, where are the connections, and can something be done around the care economy that could empower people who are part of that to play a bigger role around different age groups, different population groups, but around this also these different challenges, the climate, the inequalities issues, and just because of bringing back some of the reflection and some of the capacity and the ability to engage, to articulate, and to respond. So I'm coming to some of my own understanding of what we were discussing in the session, but I'll go around with you again to see what else, to perhaps see how we can think further on this, and maybe take us as an initiative that we could sort of start engaging with and formulating in a more articulated manner. Am I dreaming, or is it sort of realistic to try to build those connections around, first perhaps around this share economy? I open to you. Who wants to come first?
So can I have a go at that? I actually think it's critical that we do, because again, you know, whether they're workers or volunteers or indeed community planners, looking at what the needs of people are in terms of caring for them and making sure that in that care economy, we've got a perspective of not only supporting people, but what are the jobs that are necessary to make that happen. And remember, for women, when you provide care that they can depend on, it frees them to participate in the broader economy as well. So it's actually a multiplier impact itself on prosperous communities, as well as supporting people along the way. But I wanted to perhaps say that some of this conversation has to happen with the mayors and the leaders of the cities, because we know that there are incredibly, you know, visionary, progressive mayors around the world. We work with them on the questions of climate transition, electric vehicles, carless cities, mobility in terms of mass transit with our International Transport Federation, and increasingly we're working with them around these questions where people need to be at the heart of livable societies. And if you start with health and well-being, you cannot consider that the pollution levels in our cities. I mean, you talked earlier about the oxygen that young people need to develop, but they don't need polluted air. So health, well-being, you know, much more frugal use of resources. But inclusiveness, I think, starts also with not just people knowing and organising around what they want, but engaging and what we call social dialogue with the mayors that are absolutely able to bring people together around, as you said, a common platform, Carlos, if not indeed a common table.
Excellent. We're running out of time. If there's any final points, Cecilia, or over to you, Cecilia. You complete.
Yeah, maybe just to ratify the great opportunity of taking the economy of care as a topic, and just the only additional thing, because I agree on the fact that there's a need to work with different types of leaders. So it's mayor, but I would say at different levels of government as well. I do think it's important to have these champions that can actually walk the talk and that can be convinced of doing these things and actually just use them to create more awareness. I don't think it's a topic that has been, I think there's a lot more we can do in order to create more awareness of this urgent need. And just the fact of working across sectors as well. I think this remains as a challenge, even though we've been talking about like systemic actions and the importance of working across sectors, it doesn't necessarily end up happening. So I think there's something about probably bringing the discussion of the economy of care that can actually make it easier to implement the things across different sectors.
Excellent. Any very brief thoughts, Alan or Claire?
I am fully supportive of the comments from Sharon and Cecilia on care economy. I think the only other thing, and I don't know whether you can do it, is this idea of more dialogues intergenerational between, you know, even just kicking off between Cecilia and, you know, Cecilia and I in terms of aging and younger people, and how to bring those groups together, and where are the opportunities that exist if we have those conversations. And I don't think I think they're potentially very rich and rewarding. So I think there's that. I also think the national local, you know, it's not only happening within cities, but it's also very driven by national government policies. And so looking at how do we bring those aspects together, it's very relevant for care. Even if the policies are taken at national level, they're decentralized for implementation. So we need to look at where are those national local linkages, I think, as well. Thanks.
Excellent. So Claire, you're going to be closing. Over to you.
Okay, well, thank you. Yeah, no, so I too agree with Sharon and the others, absolutely. You know, the women who are seeking to secure a means to protect themselves from pregnancy, it's the same woman who is seeking clean water for her family. It's the same woman who's walking in the dark a long distance to find a bathroom. It's the same woman breathing polluted air. You know, I think one of the challenges is at least where I, as you know, I came from the Gates Foundation for a long time, and donors, I think, need to, it would be good to help donors understand the value of thinking intersectionally, multi-sectorally about these issues. They tend to be very siloed. They have separate budgets, separate outcomes, separate accountability structures for their health areas. And so it's one of the challenges. And moreover, you know, they tend to engage more at the national level than with municipal governments. I think COVID has brought attention to the city like nothing has before, perhaps. And this is an opportunity to bring together what others are calling the care, care more generally across the spectrum, and to help donors understand the value of this perspective. Thank you.
Thank you. I think we all have a work in sort of disseminating this idea, but first bringing them together, I think is a very first step, and I'm really pleased that we had this opportunity. Thank you warmly to all the speakers and to those who have been 100 people or so who were being with us during the conversation. Thank you. Bye. Very good.
Thank you.